Hi, welcome to part 2 of our evaluation of small bowel obstruction. Now, we left off last time with really beginning to think about how do we evolve around the clinical question? What do we need to answer? Well, when the clinician sends us a rec, rule out small bowel obstruction or suspect small bowel obstruction, we need to say, does the patient actually have small bowel obstruction, or are the symptoms related to another condition? Pancreatitis, acute cholecystitis, Crohn's disease without obstruction, diverticulitis, you name it. If the patient does have a small bowel obstruction, is it a partial or complete small bowel obstruction? If there is a small bowel obstruction, can we determine its cause? And when we look at all the information we have, can we determine whether or not this patient can be managed medically, or is this patient a surgical candidate? And, for example, if we see a volvulus, we know the patient needs to go to surgery immediately. When we see a hernia that's incarcerated, it's immediate surgery. Where you have some mildly dilated bowel, maybe it's adhesions, you don't see anything that impressive, that patient may be able to be watched and treated conservatively. What we see will determine what gets done. Time to surgery is the most important prognostic factor, as mortality increases with the duration of symptoms. Ritz determined that the survival rate in the first 12 hours was 84%, compared with only 11.6% after 24 hours and 2% at 48 hours. You can see high clinical suspicion. You need CT, and CT needs to be very specific as to whether or not the patient has obstruction. Now, we mentioned the most critical finding of obstruction. What's the concern is developing ischemia. If you go to the new ACR appropriateness criteria and you look up suspected acute intestinal ischemia, CTA of the abdomen with IV contrast will be the study of choice. Okay? And when you say, you look at the first two choices, CTA abdomen with IV or CT abdomen with IV, what CTA means is you're doing fast acquisition and dual phase imaging. In that article from the ACR, mesenteric ischemia is the uncommon disease affecting the small and large bowel, resulting from reduction of intestinal blood flow. The etiology of ischemia may vary from arterial occlusion to venous thrombosis or vasoconstriction. Higher prevalence in the elderly population and nonspecific clinical presentation lead to delayed diagnosis, which can contribute to high mortality rates. And this is why CT needs to be done. This appropriateness criteria you should read. Again, it's important. Acute intestinal ischemia is most commonly secondary to acute embolism to the SMA, which accounts for approximately 40 to 50% of all episodes. Acute mesenteric artery thrombosis is the second most common cause of acute mesenteric ischemia, followed by non-occlusive ischemia, and less commonly mesenteric and portal venous thrombosis. So again, you need to look very, very carefully at the vessels. In the chronic setting, mesenteric ischemia is almost always caused by severe atherosclerotic disease. That's why complications are worse in the older patient. With rare causes including fibromuscular dysplasia, median awkward ligament syndrome, dissection, and vasculitis, all things we need to think about. But again, looking at the vessel patency becomes most critical. As we mentioned, when you want to look at the SMA and celiac, particularly proximally, where often the biggest problems are, the sagittal view is really ideal for being able to quantify the degree of stenosis based on the ability to see plaque or any other process that may be causing narrowing. Now, when you talk about small bowel disease on CT, we talk about things like wall thickening above 3 millimeters. We talk about abnormal bowel enhancement, whether it's increased or decreased. Sometimes you'll have decrease with ischemia, but sometimes you'll have increased when the patient is hypotensive. One of the critical signs when we talk about hypotensive patients is bright bowel enhancement, bright adrenal glands, and a flat IVC. So what we'll say is abnormal bowel enhancement from normal becomes critical, abnormal position of bowel in a hernia or malrotation, and of course secondary signs like abnormal mesenteric fat, fibrofatty proliferation of the mesentery, mesenteric nodes are all helpful findings to us. When you talk about a normal bowel loop, what do you call dilated? Well, above 2.5 centimeters. We have other signs. We have a small bowel feces sign where you see air bubbles and intestinal content proximal to a site of an SBO. That's easier to show than explain, but it's a very nice sign to show you specifically where the transition is. We can see small bowel wall thickening, symmetric or asymmetric. Things like Crohn's tend to be more symmetric. And then we look for transition in size of small bowel loops. In this article by Scaglione in Abdominal Radiology, talking about small bowel obstruction, in high-grade or in chronic obstructions, endoluminal stasis or gas create an appearance rather similar to feces in the colon, the so-called feces sign. The frequency ranges from 6 to 37%. I have to admit, in my experience, it's far closer to 6 than to 37%. Here's an excellent example. Abdominal pain and distension, markedly dilated small bowel. You can see the mesenteric vessels are stretched but patent. But look at this loop of small bowel. It looks like colon with stool, and you follow it right to this point here. And there's definitely a transition point in the small bowel. Here it is again very nicely with a volume rendered view as well. Dilated small bowel, again the value of coronal imaging, you follow the bowel downward, and then right here you see the transition. Here's that feces sign, there's the transition, and what this patient had was adhesions, had an appendectomy 30 years earlier, and now had an adhesion that was obstructing the bowel. When you have that very sharp transition point and a feces sign, you really need to think about adhesions. Now, you could say there's an adhesion there. You're probably not going to see the adhesion because often it's the size of piano wire. It's just critically located, but you see the transition and you see the problem it causes, very nicely shown on this image. There was an article way back when in Signs of Imaging in Radiology, the small bowel feces sign, which described the sign in detail. And again, in that article, the comment was it is a result of delayed intestinal transit and is believed to be caused by incompletely digested food, bacterial overgrowth, or increased water absorption of the distal small bowel contents due to obstruction. But when you see it, it's a very, very specific sign. In that same article, bowel obstruction accounts for 20% of acute abdominal surgical interventions. In 60 to 80% of cases of intestinal obstruction, the small bowel is involved. But again, you can't always say that, well, I don't see the feces sign, so it's not obstructed. That is not going to be the case, okay? Now, we also look for other things. We look for closed loop obstruction. We look for where it's due to adhesions at times, whether it's due to an internal hernia, congenital or iatrogenic defects in the mesentery or omentum are some of the possibilities. The classic appearance of a closed loop obstruction is the C or U-shaped configuration. Now, what's very important about closed loop obstructions, of course, they are going to be surgical emergencies. So here's an example. Dilated bowel in the left upper quadrant, and you can see the bowel is edematous, and it's not enhancing like the rest of the small bowel is. And then when you look at the coronal view, you can see this kind of band and this kind of twist. We have the dilated small bowel And here's small bowel, but it's a transition point. So you have basically an internal hernia with a midgut volvulus. This is a surgical emergency. Look how nice the distal small bowel loops are. Look how abnormal these loops are. It's mass effect, it's twist, and there's decreased enhancement of bowel consistent with bowel ischemia. And here's a few more images from that case. Just a beautiful example of the twist with a midgut volvulus, very nicely shown. We see midgut volvuluses occasionally, again, acute abdominal pain, but these are surgical emergencies. That lack of enhancement, bowel wall thinning, is a common feature of small bowel ischemia. The bowel wall can become markedly thin or severely thin. And what happens, this is a result from loss of arterial blood flow, and this could easily progress to infarction, and infarction with perforation are all possibilities that occur as well. Here's another example. Dilated bowel. You really have a hard time seeing where the folds are, right? Everything it almost looks like fluid in the abdomen, but these are the bowel loops. Here's some more distal bowel that looks okay. Again, you're dealing with a midgut volvulus here. That lack of enhancement is so critical. Then when you look at the reconstructed views on the routine coronal or with the MIP imaging, you can see this haziness here. And look at the vessels going to the bowel. You can see there's a twist here. Look how small the vessels are. The vessels are really tiny, and they're kind of pruned off because you have this midgut volvulus. And the thin bowel, the lack of enhancement, is consistent with developing bowel ischemia. This is, again, a surgical emergency. Coronal view, again, nicely showing you the abnormal bowel compared to the more normal proximal and distal bowel. You need to recognize that appearance so you can make the correct diagnosis. You can see when you look at it on cinematic rendering, the bowel is edematous and inflamed, and you can see the edema. And on cinematic rendering, that looks red because it's edematous when we do this type of preset, and the normal bowel looks kind of like normal bowel. So again, a very nice example of ischemic bowel. And again, the stretching of the vessels, the twisting of the vessels, all comes together for us to make the correct diagnosis. Now, with closed loop obstructions, again, surgical emergencies, sometimes, particularly junior people, have a hard time making the diagnosis. It can be caused by adhesive bands or internal or external hernias. Closed loop obstruction can lead to a volvulus, and this leads to impairment of venous outflow, followed by intestinal ischemia due to arterial ischemia. People describe the C or U-shaped distended loops of bowel converging to the site of obstruction. I think that's a really good description when they show articles with a C loop or a U-shaped loop, but I don't think it's something I see all of the time. It's more that lack of enhancement. That closed loop obstruction depends in part on the orientation of the loop relative to the plane of imaging. If the loop is within the plane, then it appears to have that U or C-shaped or coffee bean configuration. So a lot of times you need to know that there must be a closed loop to be able to find that appearance. Here's another example. Here's a patient where you're looking abdominal pain. Look at these bowel loops. They're in the lesser sac. The stomach's being compressed. And again, you can see the lack of enhancement of the bowel, right? It's edematous. There's poor enhancement. We know this is ischemic bowel. And if you just follow it down, I'll just show it to you as you scroll through it. You can see the bowel in the lesser sac, the decreased enhancement of the bowel, the engorgement of the mesentery, and more distally, the bowel looks fine. And let's come back up, and you can see that internal hernia. And then, again, we always like to look at the coronals. So when you look at the coronals front to back, you can see the small bowel loops going into the region of the lesser sac. Look how stretched the mesenteric vessels are. All of those mesenteric vessels are edematous, shown right here. And this is just another really nice example. I'll stop right there and go back a little bit, showing you the really nice example of the dilated bowel, the lack of enhancement, and the prominence of the mesenteric vessels with decreased enhancement. And again, the coronal shows it very nicely. I'll show you that also at times the sagittal. As I mentioned, sagittal is best for looking at the SMA and celiac, which you can see right here. But then you kind of look at how the vessels twist, and then you look at the stomach and the lesser sac, and you see those bowel loops which are going into a place in the lesser sac where they don't need to be. Here it is very nicely, and here's that combination of decreased bowel enhancement, dilated bowel, stretching of the mesenteric vessels, and poor enhancement of the mesenteric vessels, midgut volvulus, ischemic bowel developing. Again, very nicely shown on these images with volume rendering and MIP imaging. So again, get a feel of how things look. In this case, you should be able to make the diagnosis. Once you see the bowel is not enhancing, that's a problem. Once you see the mesenteric vessels pointing in the wrong direction, that's a problem. Once you see the mass effect on the stomach, that's a problem. All of these put together will help you reach the right diagnosis. Another case, acute abdomen, dilated small bowel, and as you follow it downward, there is decreased enhancement. There's some ascites present. With ischemic bowel, you may see ascites, and that's not a good sign. Here again is the coronal views with MIP imaging. Again, look how small the vessels of the SMA become. They are tapering very rapidly. The bowel is dilated, there's poor enhancement. So now we're getting dilated bowel, poor enhancement of bowel, very tiny mesenteric vessels, and you put all of those together, and now we're also seeing ascites, which is a bad sign. This is pick up the phone before you dictate the case and get the surgeon on the phone. This was an internal hernia due to adhesions from the cecum to right ovary. So again, probably related to prior surgery like an appendectomy, but again, a real critical configuration. Here's a patient who had symptoms for many years, but this time presented in a way we can make the diagnosis. When you look quickly, the first thing you see is small bowel that's dilated with the feces sign. So you're talking, aha, there must be obstruction. So let's look at that a little bit more carefully. Where precisely is the obstruction? There's some fluid there, but here's that U-shaped. Remember we said C or U-shaped? This is a beautiful example of that. We just caught it perfectly. You can see the twist, precisely where the twist is. The patient had adhesions, and the distal small bowel was twisted. And here's a schematic of that showing you that closed loop obstruction, that very nice C or U-shaped configuration, depending how you think about it. And there was bands over there. This was resected. The bowel was actually able to be preserved. They were able to remove some of the adhesions, and the patient did fine. But just a beautiful example of that U-shaped configuration with an internal hernia. The same article about bowel obstruction and ischemia. This kind of small bowel obstruction presents when two adjacent sites of obstruction are present, separating the obstructed loop from the remaining segments of the GI tract, which remains of normal caliber. So this obstructed loop continues to dilate. And that's why this is a surgical emergency. This closed loop can twist along its major axis, and a volvulus, that is a bowel torsion on its own axis, may occur. And that's what you saw very nicely in the last case. Now, when you look at other images, we need to be careful to look at the entire scan. Here's a patient with a chest CT with this clot in the patient's left atrial appendage. You have to worry that clot can go anywhere. It can go to and give you PEs. It can give you a brain infarct. It could give you occlusion of the SFA and lower extremity symptoms, or it can go to the SMA. And here's the example where here's the SMA. Here's the SMA with some thrombus in place. And you track it further downward, there's no enhancement of the vessel. The reason I like sagittal views is you can see the SMA then you can see the occlusion due to embolic phenomena. Sometimes when you're looking at the axials, you kind of lose track of where you are, and you assume you saw enhancement, but then you don't really appreciate it disappearing. Here you can see very nicely the occlusion. This patient went to surgery, the clot was removed, and the patient did fine. Here's that same patient with MIP imaging, very nicely showing you the occlusion that's present. And again, dilated bowel. If this was not diagnosed, this bowel would have infarcted. At surgery, they removed the thrombus and the patient did fine. But again, you could see the patient is beginning to develop bowel dilatation. You almost begin to wonder, could there be pneumatosis? Once you have pneumatosis, it usually means the bowel is ischemic, which means you're going to resect bowel. And here's just a good example showing you that thrombus, nicely shown on the coronal view, though I will admit it was best seen on the sagittal view. So final diagnosis was an atrial thrombus in the left atrial appendage with SMA clot, and the patient beginning to develop early ischemic changes in bowel. So what I want to do is cover a number of different cases and show you the things we look at, the pitfalls, and why, if we're very careful, we can make the right diagnosis in most cases. But to do that, let's stop here and come back and pick it up in, let's say, 20 minutes. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at CTisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.